I want to do is I want to talk about the difference and the similarities between supportive care and palliative care. So as Norma has already alluded to, I'm the new professor of palliative medicine, although my official title is the Professor of Palliative Care Medicine. And one of my other significant roles is I'm president of the Multinational Association of Supportive Care in Cancer. And so I have a foot in both camps, and there are two camps in terms of both palliative care, palliative medicine, and supportive care. And hopefully over the next 35 minutes, I'll explain what the similarities and differences are and why it's important that we use the right term to describe the service we're providing, and that we develop appropriate services, as has already been discussed, for our patients. So I always like to have some quotes in my lectures. I thought I'd start with this great English philosopher, Mr. Philip Collins. And just to paraphrase him, there's a lot of misunderstanding about what supportive care is. And this was highlighted by this editorial that was in the BMJ in 2019. And it sort of brought to the head discussions that have been happening, certainly within the UK, about the term supportive care. So a number of palliative care teams in the UK over the last particularly 5 years have rebranded themselves as either supportive and palliative care teams, or in some cases just supportive care teams. And indeed, my own team in the UK, which was based in a cancer centre, rebranded itself as the Supportive and Palliative Care Team. And what the authors here were saying is that actually, you know, this is something we shouldn't be doing. We shouldn't be rebranding ourselves. We should be explaining what palliative care is, and reassuring people that it's more than just end-of-life care. But unfortunately, they and various other people have sort of missed the point as to what supportive care is. And supportive care as a sort of specialty, for want of a better term, has been around for at least 30 years. And I'll come back to the history of it a little bit later. Part of the reason why there's been a change is some of the work that's been done in the palliative care unit, or as it's now called the supportive care unit, at the MD Anderson in Houston in Texas. And so for those of you who don't know, the MD Anderson is a massive cancer center in Houston. Its education center is a tower block of 13 floors. So you can imagine what the rest of the hospital is like. They have little shuttle buses that come from local hotels to take patients to the hospital because they have so many people who travel interstate to go there for their treatment. So it's a massive organization. And they have a massive palliative care team. But what they were aware of was that they weren't seeing patients until they had very advanced disease, close to the end of life. And when they asked their oncology colleagues about that, it was clear that there was an issue around the label palliative care. And so they asked their colleagues, well, what if we changed our name to supportive care? Would you send us more patients? And the response was, yes, we would. We'd send you more patients who had advanced cancer, but more importantly, we'd send you more patients who had sort of earlier cancer. So there was a barrier to referral to this team because of the label palliative care. So what they decided to do was to change their name. So they changed their name to the supportive care team. And then they looked at what happened to their referrals. And as you can see from the text here, they had a significant increase in the number of patients referred. And not only an increase in the number of patients referred, but the time from diagnosis or to referral was much shorter. So they saw a completely different population of patients, a bigger population of patients, just on the basis of changing the name of the service. And I think on the basis of this experience, the basis of these studies, a number of palliative care teams within cancer centres, certainly in the UK, as I said, have adopted the term supportive care, either as they call themselves supportive and palliative care, or just the supportive care team. But essentially what they've been doing is exactly the same thing as they were always doing, which is providing classical palliative care. So what I'm going to talk about over the next half an hour is what exactly is palliative care. Then I'm going to talk about what is supportive care. And then a bit, this sounds a bit pompous, my vision, which is why I put it in inverted commas, my ideas about where we should go from where we are at the moment. And then just a brief conclusion. So it's very interesting, you know, you meet new people, they ask you what you do, and what do you say? I mean, this is the perception, and it's a real perception out there. The assumption is that if you work in palliative care, you spend your whole life looking after people that are dying. And we do spend a fair amount of time looking after people who are dying, whatever the definition of dying is. And everybody says, oh, it must be terrible, you know, it must be so depressing. You spend your whole time looking after people who are dying, you know, how do you cope? But that's not what we do. Although when the hospice movement was set up, it was around improving the end-of-life care. And it was around particularly the end-of-life care for patients with cancer. That was the stimulus to Cecily Saunders building St Christopher's Hospice on the basis of her experience as working as both a nurse and a social worker and looking after cancer patients. And I think I would struggle to succinctly say what is palliative care, because I think all of the people in the audience who work in palliative care have probably very different jobs. And for instance, Audrey mentioned that Norma works across 2 sites, and I think probably what she does at St James's Hospital is slightly different to what she does when she works at the hospice. And I put up the 2 WHO definitions, the original definition and the updated definition. And I think it's quite interesting that the WHO felt that they needed to adapt the definition and give a further explanation to what palliative care is. So clearly there's this belief that certainly between 1990 and 2000 there had been some sort of change. And I think if you look at what a lot of us do now, it's very different to what we maybe did when we were in training, and certainly what people like Cecily Saunders were doing when they set up places like St Christopher's Hospice. More recently, the International Association of Hospice and Palliative Care have come up with a new definition. And for those of you in palliative care, I'm sure you're aware that this has been somewhat controversial, this definition. I'm not sure I quite understand why it's so controversial. It actually came about as a result of a sort of Delphi type process where they asked people involved in palliative care, you know, what they thought palliative care was, what were the key aspects of palliative care. But for instance, the European Association of Palliative Care have not endorsed this definition. The Multinational Association of Supportive Care in Cancer have not endorsed this definition, and some other organizations have actively criticized the definition. And I'm just going to put up a couple of slides now where they talk about the features. And actually, most of these are very similar to what was in the WHO document in 2002. And I've just highlighted some important things, that it's applicable throughout the course of the illness and can be provided in conjunction with disease-modifying therapies. And probably this has been the biggest change within palliative care since the sort of development of the specialty, is that for a lot of us, we're now seeing patients not after they've completed their anti-cancer treatment and have got a limited prognosis, but actually during their treatment. And we're using the skills that were developed, the experience that we've developed, the research that was done in looking after patients with more advanced disease and extrapolating that to patients earlier on in their journey. Although the question is whether that's appropriate. And again, I will come back to that in a minute. So I'll just put this up for a short while, but I'm sure you all know about this. Now, the important thing to say is that actually the evidence base in palliative care is very poor. And most of the studies will show that have been done, will show that patients and carers are very positive about palliative care. There are improvements in quality of life. There are sometimes improvements in symptom control. But if you look at other data, we actually don't seem to be that good at managing symptoms. And some of the other sort of key endpoints that we judge ourselves on, the data's lacking about whether we actually make a difference. And some of the endpoints like place of death probably are not that important in the grand scheme of things. We've done some research with patients and carers about, what is important to them. And actually place of death falls much lower down the list than perhaps the emphasis that is put on it by ourselves and by governments. So I've already alluded to this, that, the old concept of palliative care was that, it occurred at the end of the sort of oncology treatment, but now it's a much more fluid intervention. And there's one model that I really like, and it's called the seesaw model, and it's exactly what it says. The input from palliative care varies throughout the journey, even while the patient's having treatment, and depends on the needs at a particular time. So there may be patients who present and have a lot of symptoms. Recently, we had a patient with a new diagnosis of myeloma who had a lot of bone pain, was admitted to the hospice for symptom control while continuing on with their anti-cancer treatment, and has now been discharged. And we probably will keep it under follow-up with the community team, but actually her pain is well controlled at the moment, and so our input is going to be very minimal. And similarly, other patients may need intermittent interventions and then no interventions for a long time, particularly those patients who are having some of the newer treatments and whose disease is stabilized over many months or years. So one of the things that I want to sort of talk a bit about is this issue of so-called early palliative care. And it's becoming, dependent on where you work, a sort of increasing component of what we do. But I think what's really important to understand is early palliative care just means palliative care given earlier. The interventions given in most of the studies that have been published, the positive studies about early palliative care, there is nothing different that is being done to what would happen to patients with more advanced disease. At least that's what it appears from reading the studies. And what's really reassuring is that there's now a sort of agreement within oncology of the importance of integrating palliative care, of early palliative care, particularly in patients with metastatic disease, but also patients who are very symptomatic. And this is an ASCO clinical practice guideline. This is an update of a previous one, talking about the fact that patients should be referred earlier if they've got metastatic disease, and particularly if they've got a high symptom burden or other problems that are applicable to palliative care services. And I think that's another important thing, applicable to palliative care services. And I'll talk a bit more about this when we come on to talk about what supportive care is. We are very good at doing certain things. We are very experienced at doing certain things, but that doesn't mean that we can extrapolate to all patients, to all groups of patients. Okay, so what is supportive care? So I want you to forget everything that you think you know about supportive care. And I'm going to tell you what the people who practice supportive care think supportive care is. The first thing to say is, and this is not surprising, this was a sort of review of the literature that was done in 2013, and probably, you know, the results will be even more diverse now. But what they found is when they reviewed the literature, there were at least 13 different definitions for supportive care. Interestingly, there were even more definitions of palliative care. And they looked at those definitions and what were the sort of characteristics enshrined, if you like, within those definitions. And in terms of supportive care, it was around symptom control, quality of life in patients on active treatment. And I think that's really important. So as I've alluded to, and as Norma alluded to, I'm the president of this organization, the Multinational Association for Supportive Care in Cancer. So this is, as it says, an international organization. There are members in over 70 different countries. It's multi-professional. There are a lot of doctors, nurses, AHPs, but also a lot of basic scientists involved in cancer research. And it does a lot of things. It has an annual meeting, but one of the things that it does is it produces a series of guidelines on the management of different, particularly toxicities of anti-cancer treatment. And this organization has been around for 30 years and has been steadily growing. It has strong links with, for instance, ESMO, the European Society of Medical Oncology, and also ASCO, and they write combined guidelines on certain subjects like the management of oral mucositis. And this is their definition. Now, I'll let you read the definition, but there's two important things about this. It's about the management or the prevention and management of the adverse effects of the cancer and particularly its treatment. It covers the continuum of the cancer experience from diagnosis through treatment. It includes palliative care, but it also includes those patients who have survived their treatment and the cancer. And I'll come back to cancer survivors a little bit later. And I think what the main, if you look at the people who are members, and if you look at some of the supportive care services that have been developed elsewhere in the world, in mainland Europe and in the US, you can see that although palliative care professionals do have input into these teams, the majority of the team is actually not made up of palliative care professionals. The exact mix varies hugely. And I'll explain why that is over the next few slides. So this is the strap line for the organization. So supportive care makes excellent cancer care possible. And what that means is that if you can prevent or successfully manage complications like neutropenic sepsis, oral mucositis, okay, then you can ensure that patients' treatment is not interrupted, that patients' treatment doesn't have to be amended because of toxicity, which will all improve their outcomes. So it's not just about managing the symptoms, about maintaining or improving quality of life. It's about ensuring that the cancer patients get through their treatment and get the best outcomes possible from that treatment. And that's why the organization, as I said, is very multi-professional, multidisciplinary, in that, you know, oncologists, oncology nurses and other people involved in oncology can see that the toxicity of treatments actually is having an impact on all of those factors, and is something that is important to do. And this is why in lots of cancer centers, let's say in mainland Europe and and in the US, they are developing supportive care teams which are complementary to the palliative care team. So in many centers, there is a palliative care team, a supportive care team, and although they interact, they also look after separate groups of patients. I just wanted to mention a few other things. So one is best supportive care. So this is a term that was used a lot in the oncology literature over many, many years. And this is this is an article, a review article from Nathan Cherney. Nathan Cherney is a palliative medicine consultant from Israel, who's quite high up in the ESMO hierarchy. And essentially, this term was used over many years to mean no treatment. So a lot of oncological treatments, the patients were randomized to the new treatment versus best supportive care. But best supportive care was nothing. And so many of those studies have been criticized because the outcomes are not compared against what would now be considered a standard of care, for instance, palliative care or true supportive care. So when you look back at historical studies and the control arm is best supportive care, you need to understand that that's probably nothing. Now, this is a very English term, enhanced supportive care. So this is a program that was developed at the Christie Hospital by Dr. Richard Berman. So Richard is very pro-supportive care, and indeed the palliative care team at the Christie have been rebranded as the supportive care team, and he is no longer a consultant in palliative medicine, he's a consultant in supportive care, although there is no defined specialty as yet. And they have developed this model of supportive care, on the basis of their results, NHS England have funded all of the other cancer centres in the UK to develop a similar model of care. Now, some of the results from the Christie are very impressive, but one of the things you have to understand is the Christie is a standalone cancer centre on the outskirts of Manchester, and there's no emergency department. And so it's very easy to prevent admissions to the Christie by redirecting patients to other general hospitals within Manchester. But what this service has shown is that as a result of enhanced supportive care, there has been improvements in patients in care in different domains, and a significant saving, which is the thing that NHS England were very happy about, significant saving in terms of length of stay and use of interventional treatments at the end of life. So NHS England have rolled this out. Now, I don't know where the enhanced supportive care came from, because essentially this is early palliative care is what they're doing. Unfortunately, they have not rolled out a standard model of care. So all of the enhanced supportive care services in the UK are very different. Their makeup is very different. Some of them are an extension of the palliative care team. Some of them have no input from palliative care at all. There is one service that is run purely by AHPs, physiotherapists and occupational therapists. And so the service that's being provided is very different. And so it's very difficult then to look at what the outcomes are and whether these outcomes are relevant to the whole supportive care program. But what is important to understand is that supportive care is not the same as palliative care, and it's not even the same as early palliative care. And I'll explain why. So the first part of the MAST definition talks about the prevention and management of the adverse events of cancer and its treatment. I think in terms of managing the adverse effects of the cancer, that's something that we within palliative care are very good at. In terms of the treatment, it's something that we don't have a lot of experience of. And as Norma alluded to, oncology treatment has changed dramatically over the last few years and is continuing to change. In terms of things like immunotherapy, the toxicities that these patients are getting are completely different in many cases to the toxicities that we used to see in patients having chemotherapy or radiotherapy. And it's likely, as treatments develop over time, that we will see even broader range of toxicities. And we are going to need to understand the underlying mechanisms of those toxicities, and we're going to need to do studies into how to manage those toxicities, not only reverse the toxicity if possible, but also to manage the symptoms. We can't assume that the treatment for breathlessness due to an advanced lung cancer is the same as the treatment for breathlessness due to pneumonitis. And just to highlight this, these are two mask guidelines. So the one on the right was one I was involved with, and these are mask ESMO consensus guidelines on the management of nausea and vomiting in advanced cancer. So the first thing to say is, despite the fact this is one of the commonest symptoms we come across, the evidence base is really poor. And so there are some recommendations in there, but they're based on very small studies, poor quality studies, and predominantly on expert opinion. And actually, the strongest recommendations are things that you shouldn't do or shouldn't use first line. And doing these sort of reviews, writing these guidelines in advanced cancer is very depressing. Because you make the assumption that there must be good evidence to support your practice, and invariably there isn't. So the document on the left was published about the same time, and this talks about the prevention and treatment of chemotherapy and radiotherapy-induced nausea and vomiting, and that is completely different. If you look at some of the algorithms for managing chemotherapy induced nausea and vomiting, for instance, there are specific treatments depending on the regimen that you're having. There's first-line treatments, there's second-line treatments, there's treatments for preventing nausea and vomiting, there's treatments for, so there's algorithms for refractory nausea and vomiting, there's algorithms for delayed nausea and vomiting. And they use drugs that we can traditionally don't use that much within palliative care. So things like 5-HT3 antagonists, NK1 antagonists, we know about them, we have some experience, but they're not the things that we use on a day-to-day basis. So if we're going to get involved in supportive care as a specialty, then we're going to have to make sure that we know what we're doing. We're going to have to, read the literature, keep up to date with the literature, and we're going to have to change our training to ensure that people coming through have the right skills. Importantly, what we need to do is understand the limitations of what we currently do, and so not go in and see oncology patients who are having treatment and give them what we would give to somebody who's completed their treatment with advanced disease. It may be the right option, but it may not be the best option. And so we need to understand that if we're going to maintain our credibility with our oncology colleagues. Okay, and I talked about new toxicities or unusual toxicities. So this is not a new problem as such. So just to orientate you, that's somebody's mouth, that's their lower gingival margin. You can just see a tooth at the bottom right-hand corner. So this is a patient who had no symptoms at all at this point, and noticed that there was an ulcer on their gingival margin. And a number of people looked at this and didn't know what it was. Okay, so this is bisphosphonate associated or related osteonecrosis of the jaw. So, you know, most palliative care people may be aware that bisphosphonates cause this problem, but not the clinical features. They may know how to manage it, but they wouldn't manage it, or they shouldn't manage it. And that's the issue about supportive care, is that there are a number of toxicities where actually, even if we can diagnose the problem, even if we understand what the treatment is, we shouldn't be given the treatment. This patient needs to be referred to an oromaxillofacial surgeon who has an interest in this and knows what to do, or more importantly, knows what not to do. And this is, for instance, is going to be a problem we're going to see more often, because more patients are going to be on highly potent bisphosphonates. And as I said, you know, this is asymptomatic when it first presents. I mean, as the disease progresses and infection and the necrosis extends, and it does tend to become symptomatic. But it's important to pick up these patients as soon as possible, to initiate appropriate treatment, to not do certain things like invasive dental procedures. And what's most important is the prevention. And again, this is something that really doesn't fall under our remit. But anybody who's going on a bisphosphonate, unless they're going to be treated for hypercalcemia, which is a medical emergency, if it's calcium's very high, should be having a dental review beforehand. And if they have significant dental problems, then these need to be addressed before the bisphosphonate starts. So the whole oncology practice has changed. You know, there may be a case for patients with really advanced disease who's got significant problems with pain for us to get involved, but for the sort of primary management, this is not our area of expertise. And then there's the whole issue of cancer survivors, which is, you know, becoming an increasing issue worldwide. How do we manage these patients? We know that these patients have ongoing problems as a result of their treatment. And when I talk about cancer survivors, I know that there's a very broad definition. I'm talking about people who we assume are cured of their cancer. They completed their treatment. There's no evidence of disease. That group of patients have ongoing physical problems. How do we manage those problems? Again, we can't extrapolate from patients with advanced disease, particularly in terms of pain, because these patients have chronic cancer treatment-related pain, and that's akin to non-malignant pain. And for instance, you know, in terms of the use of opioids, we need to be really careful about using it in cancer survivors. There may be a role, but a much more limited role than in somebody who has advanced disease that is progressing. And again, we as a specialty, you know, are not as skilled at managing non-malignant pain, most of us, as we are at managing cancer-related pain. So hopefully, you know, these slides are sort of giving you a flavor that supportive care is something that we should be involved in, but actually it's much bigger than palliative care. It's much bigger than early palliative care. So my vision. So it is clear that we need palliative care for patients with cancer, and we need supportive care. And actually there's a big overlap. There would have been a bigger overlap on this slide, but if you did that, then you obscured the text. So that's why the overlap is relatively small, but I think the overlap is much bigger. And what we need to do is decide what is the involvement of the palliative care professionals in the supportive care service. And this is a model that, if that's the correct term, that's been developed to show that actually, if you're going to provide good supportive care for these patients, you need input from all of these services. So palliative care is important. The acute oncology team is really important for managing the acute toxicities. And certainly at the Christie, they have joint clinics between the palliative care team and the acute oncology team. And they will do joint reviews as well. And then depending on what the problem is, the acute oncology team may take the lead, or the palliative care team may take the lead. But, you know, for instance, things like osteonecrosis of the jaw, then clearly you need specialist input from oromaxillofacial. So we need to develop a service that's fit for purpose, which includes palliative care, but more than palliative care. And this slide is really represents my idea for palliative care and supportive care within oncology. I think traditionally it's been seen as the cherry on the cake, you know, the cake being oncology treatment, and, you know, it's an add-on. It'd be nice, and if you can have it, but actually we need to have the vision on the right, that palliative care and supportive care is embedded within the cancer journey. I think I'm getting close to the end of my time, so I will speed up a little bit. And I think what some of us are coming around to the idea now is actually we need a subspecialty of supportive care, because it's such a diverse field. And as I said, due to the developments within oncology, the sort of problems we're seeing are very different to what we're used to, and we need people who have the time to keep up to date and to develop new skills in managing, you know, different problems. So maybe sometime in the future there will be a distinct specialty or subspecialty of supportive care. Okay, so I've come more or less to the end. I apologize to the oncologists in the audience for this cartoon, and I won't tell you the palliative care joke about, you know, why they screw down the lid of the coffin or why they bury the coffin 6 foot under, because that's not conducive to good working relationships. But I think it's great that we have had the developments that we've had in oncology and that patients are living longer. But it shouldn't just be about living longer. It should be about maintaining and improving quality of life. And I think, you know, more or integrated palliative care, integrated supportive care is how we can best serve our patients. I've left you with another quote. I couldn't find a suitable Philip Collins quote, so I've left you with you know, a quote which I think is still relevant now. I mean, luckily we are curing more people. We're certainly making them live longer, but we should never forget that we need to comfort always. And finally, a very cheap plug for MASK and for the MASK annual meeting, which is in June of this year. It's going to be a virtual meeting. It was supposed to be in Seville, but if I piqued your interest, then please think about joining this meeting. There's a big palliative care group within MASK. There'll be lots of interesting lectures and research presentations. And thank you very much.